Hi everyone, today we're diving into the science behind hemophilia treatments. If you haven't watched my previous video where I go over the basics of hemophilia, I recommend checking that out first. Hemophilia is a bleeding disorder caused by the deficiency or absence of specific coagulation factors in the blood. Without enough of these factors, blood cannot clot properly. In this video, we will explore 4 major treatment approaches: factor replacement therapy, bispecific antibody therapy, hemostatic rebalancing therapy, and gene therapy. Factor replacement therapy has been the gold standard for treating hemophilia A and B for decades, and it remains the most common treatment option worldwide. The idea behind the factor replacement therapy is straightforward. We directly replace the missing coagulation factor through intravenous infusion. Once these factors are infused, their levels in the blood rise almost immediately, helping blood clot more effectively. However, the effect is temporary because these proteins are naturally broken down and cleared from the body. Within days, factor levels drop back to baseline. That is why patients need regular infusions. Exact schedule of treatments depends on the type of factor product, severity of hemophilia, and patient's needs. Factor products are grouped by their half-life, the amount of time it takes for clotting factor activity in the blood to fall by half. Standard half-life products require more frequent dosing, often 2 to 4 times a week for hemophilia A and 1 to 2 times a week for hemophilia B. These are usually plasma-derived products. Extended half-life products last longer in the bloodstream, so patients need fewer infusions, about twice a week for hemophilia A and once or twice a week for hemophilia B. These products are recombinant. Ultra-long half-life products are designed to last even longer. They are currently available only for hemophilia A, with dosing roughly once a week, and these are also recombinant. Plasma-derived products are made from donated human plasma and undergo viral inactivation processes to remove pathogens. On the other hand, recombinant products are produced in culture cells using genetic engineering, then processed into powder and reconstituted with sterile water before injection. Factor replacement therapy can be given prophylactically, which means to prevent bleeds before they happen, or on demand, which means after bleeding has already started. One major complication of this treatment is the development of inhibitors. Inhibitors are antibodies that neutralize the neutralized infused factor, making treatments much less effective. Inhibitors usually appear within the first 75 exposure days, and they occur in about 20 to 30% of previously untreated people with hemophilia A and 3 to 5% of those with hemophilia B. Despite this risk, factor replacement therapy remains the most widely used and effective treatment across all age groups. Bispecific antibodies are engineered Y-shaped proteins that can bind two different targets at the same time. In this case, factor 9A and factor 10. By bringing these two factors close together, bispecific antibodies mimic the job of factor 8, allowing factor 9A to convert factor 10 into factor 10A. This triggers a burst of thrombin production, a key enzyme that turns fibrinogen into fibrin, forming a stable clot. This therapy is preventive. It is not used to stop active bleeding, but to reduce the chance of it happening. Major advantage of this treatment is that it is given subcutaneously, meaning under the skin, rather than intravenously, making it much easier for infants and people with poor vein access. The best-known example of this treatment is emicizumab, which works for patients with or without factor 8 inhibitors, including those with severe disease or moderate disease with severe bleeding pattern. Dosing can be weekly, every 2 weeks, or every 4 weeks, depending on patient's preference. Emicizumab has a long half-life, low immunogenicity, which means it has a low chance of triggering an immune response, and it is not recognized by anti-factor 8 antibodies. It is important to note that bispecific antibodies do not raise actual coagulation factor levels. Instead, they bypass the missing factor's function. Currently, bispecific antibody therapy is only available for hemophilia A patients. Unlike factor replacement or bispecific antibodies, which increase in clot-promoting activity, hemostatic rebalancing therapy works by reducing the body's natural anticoagulant activity. In hemophilia, clotting factor levels are low, but anticoagulant levels remain normal. This imbalance makes bleeding more likely. But by lowering anticoagulant activity, the balance can shift toward clot formation. Hemostasis begins with extrinsic pathway, which is activated by tissue damage, and is amplified by the intrinsic pathway, which is activated by blood vessel injury. Both pathways lead to thrombin production, and thrombin then converts fibrinogen into fibrin to form a clot. There are two main strategies of hemostatic rebalancing therapy. Monoclonal antibodies block tissue factor pathway inhibitor, or TFPI, and increase thrombin generation in both hemophilia A and B with or without inhibitors. Small interfering RNA, or siRNA, reduces the production of antithrombin, thereby boosting thrombin generation. This approach also works for both hemophilia A and B with or without inhibitors. These therapies are given subcutaneously, and like bispecific antibodies, they do not raise factor levels, but instead adjust the clotting balance. Gene therapy is the most revolutionary approach because it targets the root cause of hemophilia. Instead of repeatedly infusing missing factors, gene therapy delivers a healthy copy of defective gene into patients' liver cells. The delivery vehicle of gene therapy is usually an adeno-associated virus, or AAV. This viral vector has been modified to prevent it from causing disease. Once they are inside the cells, the gene instructs them to produce functional coagulation factor proteins. Potential benefits of gene therapy include one-time infusion, long-term factor production, and reduced bleeding episodes, and avoidance of routine prophylaxis in many patients. However, there are limitations. Gene therapy is currently approved only for adults, and not all patients produce enough factor to stop prophylaxis completely. Factor levels may decline over time as well. For example, with Roctavian for hemophilia A, average factor activity is about 42% after 1 year, 23% after 2 years, and 15% after 3 years. Long-term durability of this treatment is still unknown, since trials only began in 2011 for hemophilia B and 2017 for hemophilia A. Gene therapy does not change reproductive DNA, so the corrected gene is not passed on to children. Even with these uncertainties, gene therapy represents a major leap forward, shifting treatments from managing symptoms to reprogramming the body to make its own own coagulation factor. That is current science of hemophilia treatment, from traditional factor replacement to innovative bispecific antibodies to clotting rebalancing strategies and groundbreaking gene therapy. Over the past few decades, the progress has been remarkable, and research continues to make treatment safer, more effective, and easier for patients to use. I hope you enjoyed this video. Like, subscribe, and comment if you have any question. Thank you.